I recognise some faces, which is fantastic. And those that I haven't recognised, I hope you go away smiling, at least, about something with the presentation. There's the grand opening. It can be a bit dry, so if you can do the Slido piece, if you could pop your cameras out and hopefully get onto that. It always worries me when I try a bit more technology. Just anybody say if it's happened? I've got one thumbs up. Yeah. Oh, that means you've got to answer now. Okay. With a mixed audience, it's always a concern of where we pitch this, because obviously, a bit like the keynote this morning, we all have our own disciplines and areas of expertise that we focus on. So it's about adult social care. So one of the first things I'd like to ask is, what comes to mind when you hear adult social care? So hopefully you've got a box, if the technology is working. You've got a text, yes?
Good.
We've got a text box you can write something in. I think it's probably one word you might have to write in rather than a whole text.
Or a phrase.
Oh, look, here we go. Good.
So a word or a phrase.
Yep.
No right or wrong answer. So anything that comes to mind. Wow. Yeah.
We've got the right audience. I can see some people still frowning at their phones, so perhaps it's a... So, key things coming out are in the green, obviously. Elderly, mental health, care work, the vulnerable population probably. Community, care home. My father, so there's something of a personal nature there, which I'm not surprised about. Yes, it can be complex. Ensuring the elderly needs are met. Inclusion, as I say, there's poor pay. I'll tell you what, that's going to come up in the findings. So somebody knows a bit of insight there. Absolutely, and I'm glad you've got some idea, because again, with any topic, you have to be careful of making assumptions of what people know. Some of you will have personal connections because of adult social care. Some of you will sort of think, oh, it's a bit like nursing or the NHS, and it is quite different. So if we actually think about what adult social care is when we look at the text, it is about really looking at a wide range of activities, and they could be older people or people living with disabilities. And they could be physical disabilities, they could be mental health, as you put up there. And it really is about helping them to be independent and stay, living as well as they can and to be safe. What we need to remember, it can include personal care, and it really is about keeping people in their communities. Now, that community may be their home, or it may be a facility such as a care or residential home. It doesn't tend to be hospitals or hospices, because that's more health and social care. We have got a Department of Health and Social Care, but the dominance of that is health. And if you ask people about the NHS and health, they're much more familiar, and sort of more terms would come up. It is delivered in people's home, and that's known as home care or domiciliary care. It can be in day centres, residential or nursing home, again, depending on the level of care that person needs and the type of facilities in that home. But it can be also reablement centres. So it may be temporary for a while, the physical or mental health piece. Most of it is provided by local authorities. They certainly are in charge or responsible for assessing the needs and if there's eligibility of funding. Now, the big thing around funding is not everybody gets it. It is means tested. So if you've got a chunk of savings as you start to get older, the Department of Health and Social Services will look at those savings and you contribute towards that care. So those of you that put Dad or my father up there, you're probably very familiar with that. And it actually costs the government currently, of stats for 23-24, 32 billion, but that's going to go up. And that's just on social care, that's not the NHS. So it's a huge consideration for the society. Now, don't look at me as a reference for that 65 piece. But in the next 10 years, well, it's actually 9 years, isn't it? 2035. How many people do you think will be over the age of 65?
In England or?
In the UK, yeah. Yeah, not internationally, in the UK. Oh, we've got a clear winner there at the minute.
Yeah. 16.9.
16.9, I think, is the biggest majority we've got there, and it's absolutely there or thereabouts. It's a huge number, and that's about an increase of about 10% of what we've currently got. Now, the big concern about that is we've got an increasing ageing population. Comes with that is increasing needs, both physical and mental health needs. But you start to look at the literature as well, and it starts to talk about older person as 50. So I'm in that bracket. I don't mind admitting that. I think they used to use the term 65 because that was a general retirement age from a government perspective. But you can see that those needs are going to increase. We've currently got a workforce. Now, when we talk about the workforce, it's those that are employed in posts. The care homes, the day centres, the nursing homes, the domiciliary, the private agencies that deliver this. So there's 1.7 million posts in the care sector. What do you think the vacancy rate was of 24-25? Oh, you're very pessimistic, aren't you? The vacancy rate is actually 7%. Now, that doesn't sound too much, but just post-COVID, it was up at around 10.5%. But the reality is there's a turnover of staff of about 25%. So even though the vacancy rate isn't too bad at the moment compared to other years, there is a huge turnover rate of 65%, and they themselves are an ageing workforce. So there's going to be about, I think it's well, I don't know the number actually, but there's a vast majority, about 10% or so, that are going to hit the sort of the retirement or leaving age that people look at. This is only the post that we look at for the workforce. This does not include the unrecognised care that's given by family and friends and volunteers. There's a huge sector there. But this study actually focused on the workforce.
Thank you.
I've got to sit down and behave now.
Thank you so much. And I think that leads us nicely into why this study. Because you expect that for a study, for a sector that is very, very important, that costs the government over 32 billion annually, and also that because of the type of population that we have as well, you expect a focus on those people that work, that support, that enable, that also empower, the people in these categories like Karen shared. So you expect that there will be a focus on them. Unfortunately, we do have the numbers. We know that there are challenges. We know that there are shortages in the workforce. But what we don't understand is that how are these health workers trained? How are this workforce trained? Do they have access to training? Do they have access to support? And not only at individual level, but then at organizational level as well, looking at the systems that are available to them to provide that support. So we decided to pull ourselves together, the partners. I said pull ourselves together because we actually understand the strengths that we individually have. And it was interesting in the morning when our keynote speaker was talking about collaboration. So this project is about collaboration, it's about partnership. And it was about being intentional as well to look at the workforce, to look at their education, to look at their training needs, and to assess their barriers. So there were three of us. We vended the project. So there were three of us at the university, and we brought in our expertise in research, in evaluation. But then there is the Buckinghamshire Health and Social Care Academy that have this strong strategic collaboration with local authorities and local systems across the our integrated care system, the Buckinghamshire, Oxfordshire, and West Berkshire. And of course, we have the Royal Society of Public Health, whose domain is about education, is about training, is about developing training and supporting our workforce. Our vision, I'll say, was simple, but very, very important in terms of mobilizing and integrating evidence-informed solution towards education, training, and development for our social care workforce. So we wanted to come together to look at what are those things that are hindering people from working in the social care sector, especially at the entry level. I think one of the things that drove the project was about our flexibility, our responsiveness. And because we have this ambitious plan, we needed to have a very strong governance structure. So right from the beginning, we set up the project oversight group that helped us, shaped us, worked with us rather to look at ensuring that our activities align with our timelines, the work streams are speaking, to those questions that we want to answer. But then also importantly, and in parallel, we have also the expert reference group that do have extensive experience in the sector, and they equally shaped those key activities. I talked about responsiveness and flexibility because we wanted to identify, produce, evidence-based, evidence-informed solution. So we needed to have that integration between the project oversight group as well as the expert reference group, and working with all our stakeholders, not only stakeholders in terms of policymakers, but then also in terms of practitioners themselves. And I'm going to talk a bit more about that when I'm talking about the work streams. So evidence, very important for us in order to be able to identify the solutions. So we identified the practitioners, the policymakers as assets, not as the problem. So we work with them to look at what those issues are. So we started with what are those current evidence in terms of workforce, social workforce. How have they been trained? Are there documented barriers? And this, although the study was limited to the Bob area, Buckinghamshire, Oxfordshire, and West Berkshire, but of course, our literature review was across the UK. So we looked at the current evidence in terms of how the workforce have been trained and what their barriers and motivators are. But then we went ahead to discuss with the practitioners. So we wanted their voices to shape our findings. So they also contributed, we validated the results that we are getting from the evidence with them. So for a lot of things related to workforce development, workforce training, sometimes what you find is that the voices of the practitioners themselves are left out. And that is not right. We talked about co-production in the morning. So it's about developing solutions by the people that need the solutions so that there will be ownership and so that there will be sustainability. Because for a lot of these projects, once funding ends, there may be issues. But then if we have worked with community assets, if you have worked with people, and you have worked with organizations and policymakers, then they are going to continue. So we had focus group discussions with practitioners in order to get those voices into what we're trying to co-produce. And we had the expert reference group. We held workshops with them. They also helped us to validate the findings from the literature as well as the findings from the practitioners. I think this keeps going up and down. Yeah, with the practitioners. But also very importantly was that the practitioners as well as the experts also helped in the development of the training, which was led by the Royal Society of Public Health. I think one of the ways that the Project Oversight Group also helped to shape and to govern was that when there were issues, when we had challenges, they were our reference points. They were able to say, okay, why don't we do it this way? Why don't we offer much more? Why don't we widen, the participation? Why don't we use maybe virtual training also rather than in-person training? One of the findings from the literature review showed, and from the focus group, showed that people wanted more of face-to-face type of learning. So I will quickly talk about. Okay. Yes. Yeah, you can talk about.
You can see we've rehearsed this, can't you? But this is the fun stuff in a way, isn't it? The findings. Of those participants, we had to run about 7 or 8 different focus groups to get a participation rate up to about 30. And the workshops also with the expert reference group, we did 3 of those. And that was one of the things about the flexibility and working with the stakeholders, was really trying to get a rich amount of data. Having looked across all of those work streams, so the literature itself, the wide scoping that Adetoro has just spoken about, the participant focus groups, the workshops with the expert reference group, and the experience of the pilot cohort teaching that was done by the Society of Public Health. These were the findings, and you've probably, oops, this is clicking. These are the findings. There's an increase in demand. There's no surprise there. We've already hit upon that a little bit. But there are actually a lot of gaps in the skills training and understanding career pathways. The reason there's that high turnover is because people then don't know where to go next. And it was very clear that both the practitioners themselves and some of the expert reference groups, the managers, didn't know about the next step in the career. Now, there are different patterns of career pathways and how to get up to sort of advanced sort of positions, but they're not clear and people aren't following them. So they get frustrated and they leave. Again, no surprise there. Work satisfaction, somebody put pay. Pay is poor. It is. But the satisfaction wasn't just about pay, it was about them being valued. It was about them having opportunities. And it is, I come from a background of nursing, and I make no apologies, but I started my job at 13, 14 in a care home. So I know what that's like. So again, my discipline is that side, but to hear it come through was still quite powerful to hear what was being said many, many years on from when I started. There's barriers to funding. Again, these are a lot of private or council-led care facilities or private agencies themselves. So there's not a government funding for training there, apart from apprenticeships. But again, it was not understanding how apprenticeships work and the levy payments and everything else that I think us as a university we've soon learnt about. The teaching design, they have to, when you come into adult social care, you have to do what's called the care certificate, health and safety, moving and handling, infection control, lots of basics, including communication. But that can be done on a CD-ROM in some places, or you can do it sort of with a training piece. So it's very varied. And in order to increase their skills and up their ability, one thing that came through was about digital. There was a lot of worry within the practitioners about cyber security, as well as digital enhancements to their care. But it was like very difficult for them to think about where that training would be. And it was actually the culture. It's, you're entry level into this career. It's not very well recognised, unlike nursing and the NHS. But actually, it's about training you to do the job. It wasn't really about learning and enhancing, which is something, as an academic, that's disappointing for me. They were the key findings. So you can see from the literature, again, that demand piece, the work satisfaction. So again, it wasn't necessarily new evidence, but it was further evidence to increase the evidence base that was there. And again, we triangulated that literature review scoping with the participants, with the expert reference group. So quite a few bits came through there, as you can see. I won't read them all out because I'm mindful of time and lunch. We're between you and lunch. The practitioner voices, I think, were the things, again, involving the stakeholders themselves was really, really powerful, and that goes back to that sort of collaborative and stakeholder piece. They really did not know what was available for funding and what they could do. When they started to do the cohort, the pilot training for the Society for Public Health, they thought there was some catch because it was free, so part of the funding enabled these pilot cohorts to be run, and they thought it was, can't be true, it can't be of any value if it's free. So there was a lot of sort of cultural piece and understanding tied up with around the funding and what they're allowed to do. And one of the barriers again was time. We train you to do it, once you've done it, that's it. The time about that learning was a bit of a challenge. Sorry about the ASCW, Adult Social Care Workforce. I've realised I put something in there as a bit of a shorthand. But a lot of it also was they wanted to know about their own support for mental health and well-being, not just the mental health and well-being of the patients and clients and residents that they were looking after. I don't know how well that's visible, but I was trying to just differentiate between the two work streams there. I'll just let you have a look at that. Again, it links through. There's nothing really surprising. I think what they were trying to understand is that, they realise that their staff need support and that they're vulnerable, but it was all about funding again. They recognised it, but their funding was restricting them. Funding again on this page. And there's no quick answer to that. I mean, there's a lot across the press that's been there lately, and that may have triggered, someone's response about poor pay because it is recognised there. So, of all those findings, there's no surprise, and there shouldn't be with the recommendations that come through from findings. But what we did do is think about where do we pitch these, and therefore how do we sustain this project beyond the timeline itself. So we categorise them under the care provider organisations, in other words, those care homes, the residential homes, the day centres, the agencies that provide domiciliary care. And it really was around that learning culture, understanding the knowledge gaps. Digital, as I say, was high on that one. And the support systems. Staff wanted support rather than pay. They just wanted to be able to talk to somebody, feel that they were valued, have support to go and do training. It wasn't just about the pay itself. The policymakers and the regulatory bodies, it really was to improve that portability of training. So if they did a care certificate with one agency and completed their 15 standards there and then went to another agency, they had to redo it. And of course, yes, any employer may have a different category, but what happens is it's not constant. You come to a university, you get a degree is recognised. Whereas in this sector, the training and the regulatory parts are not. And then there's a lot of work that's been done at the higher end of the career progression, the extended role, the advanced role, but very little done at the early career to keep people in and going through. And then obviously as training providers, it really was about, we know this is what our bread and butter is probably, the delivery, where they wanted it multi-mode, they wanted practical skills to be delivered face-to-face, but other things to be online because it was much, much easier and much more portable. There were challenges, there always are, I think, with any project. Stakeholder engagement was one of them. Oh, I'm being waved at, that's my 5-minute warning, which is good because we're nearly there. Stakeholder engagement, again, the expert reference group were really helpful there. We actually went back to ethics at one point because we weren't getting engagement from focus groups. So we thought, do we go down sort of the questionnaire route now? Do we change our methodology? So we went back to ethics and it was yes, so we could use either. But as it happened, somebody managed to open a door and we got the participants. And again, it's a bit of a closed sector. So as much as we're a university and the Bucks Health and Social Care Academy is about health and social care, and the Royal Society of Health is a national recognised, it was getting the right people to understand what we were trying to do. Oh, there we go. That's timing, isn't it? Okay, just one more bit on the challenges. It really was about that engagement, that partnership. So I think it was really like any piece of work. If you can find that influencer, the one to open the door, it makes all the difference. There's a lot of information there. Thank you for listening. You looked attentive, so I'm going to assume you were listening. But also, if you do want any more information, the whole report is written up on the website, and you can get a direct link with the QR code. Thank you.
Thank you.